You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 2nd, 2021. This week, two announcements: messenger RNA vaccine-induced myocarditis, diabetes in kids, optimal medical therapy for coronary disease, and alcohol. The first announcement is that This Week in Cardiology will take a break next week to celebrate America's independence from Britain. The second announcement is that new interns and fellows started yesterday. July 1 always reminds me of why I love being a doctor, perhaps now more than ever. The greatest thing about this job is that we're paid to help people. Whenever I get down, I try to remember that. Helping people, of course, comes in many forms. You can help people with ablation and stents and valves and pacemakers, even medications. But the main way we can help people is even simpler. It is to care. Just by caring, we help. And I say congratulations to all the new doctors out there. The next topic is COVID. Another week has passed, and again, COVID case counts in the U.S. remain super low. There are, however, some focal areas that are seeing surges in cases. I'll link to a news article from Springfield, Missouri. These are areas of low vaccination and high rates of obesity. Now, this is exactly as my moonlighting pulmonology friends say. They say that in rural areas there are still folks with COVID in ICUs, and all of them are unvaccinated. I led the podcast with a note about American independence. Well, sometimes rebelliousness is counterproductive, especially in a pandemic. The story from Missouri depresses me because it would be awful to repeat the stress of 2020 in the hospitals and community. But the good news is that I have seen no evidence that this Delta variant is escaping protection from vaccines. Next topic is COVID vaccine-induced myocarditis. Now, JAMA Cardiology has published two further case series of myocarditis. One was a case series of 23 male patients in the military who developed myocarditis within 4 days of receiving the messenger RNA vaccine. 20 of these 23 cases occurred after the second shot. Now, all patients had significantly elevated cardiac troponin levels. Another paper, Duke University authors report on 7 cases of myocarditis, 4 of whom had been given a messenger RNA vaccine in the days before. 3 of these were young men, and 1 actually was a 71-year-old woman. All 4 of these patients had significant troponin elevations and severe chest pain in positive CMR scans. Now, I realize that this is a contentious issue. I've discussed it on this podcast the last 3 weeks. Well, this week I put my thoughts into words in a column on theheart.org Medscape Cardiology, and I would be extremely grateful if you all took a few minutes to read it and comment. In the column, I discussed the nature and implications of myocarditis, the statistics of COVID-19 risk versus myocarditis in this young age group, the arguments for and against vaccination, the role of shared decision-making among parents and teens, and of course the implications of absolutism in vaccinating this segment of a population. One of the things I worry about is whether absolutism in the discussion of vaccines, like anyone asking questions, gets tarred as anti-vax, and also the downplaying of myocarditis in the young mixes with this American rebelliousness and fierce independence, and maybe this impedes vaccine uptake. I work in Kentucky, and I see all sorts of people here. Some patients clearly respond to empiricism, but some not so much. And I'm not saying I could do it any better, but gosh, sometimes I think the public messaging in this pandemic could have been a lot more humbler and more nuanced, and maybe that would improve vaccine uptake. I will give a link to the column in the show notes. Next topic is diabetes. 2 studies presented at the ADA meeting really struck me as concerning. Now, I'm neither a public health doctor nor pediatrician or diabetes specialist, but my heart sank when I read the headline, quote, "Staggering doubling of type 2 diabetes in kids during the pandemic." I mean, type 2 diabetes in kids? Really? Now, I realize that type 2 diabetes is one of those conditions, kind of like hypertension, that is being broadened by a lower bar for normal. But an increasing incidence of metabolic disorders in kids is an obvious concern for those of us who treat lifestyle-related diseases such as atrial fib and coronary disease. The studies, one from a group in Washington, D.C., the other from Louisiana, were both observational and ecological. And what I mean by ecological is that they compared a chunk of time before and then a chunk of time during the pandemic. Both studies found that the rise in type 2 diabetes during the pandemic wasn't only in outpatients. Both groups noted increases in hospitalization for serious diabetic issues like DKA, for instance. And both studies found disparities based on race, with African American kids more adversely affected. Journalist Miriam Tucker has excellent coverage on Medscape. And based on my estimate from my clinic, namely that at least 9 out of 10 patients have gained weight and lost fitness during the last year, it seems highly unlikely that these were statistical aberrations. Why wouldn't kids without in-person school and gym classes and sports and time with friends eat more junk food and gain weight just like my adult patients? And I highlight these observational studies for 2 reasons. First, in the last year and a half, communicable diseases have rightly garnered most of our attention, obviously. But it's not as if non-communicable diseases stopped. And any amount of type 2 diabetes in children seems like an urgency to me. But when the incidence doubles, it seems like an emergency. I mean, what do we think will happen? What do public health experts think will happen in 10 to 20 years with increasing type 2 diabetes in kids? The second reason I mention these abstracts is that they underscore the harms of an intervention. And a patient asked me this week, "Doc, what if I didn't do this procedure? What would happen?" And before answering with the specifics, I told the patient that I absolutely love this question, because in my humble opinion, too few doctors consider the counterfactual of not intervening. Now that is largely because we, as doctors, and this includes me, have an optimism about our healing powers. I mean, we have intervention bias. Well, the pandemic interventions are a shining example of harms from intervention. Now, no doubt, early in 2020, it was totally reasonable to err on the side of caution, shut down schools, daycare facilities. No one knew what was going to happen. But at some point, and we can argue about when that was, we learned that children were at substantially lower risk from the virus. Private schools opened, and so basically for the rich, pandemic life was much less disrupted than for the less well-off. So not only did the pandemic interventions cause harm to children, say in the matter of increasing type 2 diabetes, these 2 studies support something that should have been obvious. Kids with less means were harmed more by these interventions. And my point here is not so much the rightness or the wrongness of the lockdowns and school closures. I mean, it was a once-in-a-lifetime pandemic after all. It is simply to remember to always think about the harms of intervening and the counterfactual of not intervening. And I think this is a perfect lesson for July 1st new doctors. The next topic concerns medical therapy. A study published recently addressed the question of optimal medical therapy in patients with stable coronary artery disease. And stable CAD is another way of saying the person has atherosclerosis of the coronary arteries. And atherosclerosis is a systemic disease, and I've always had a strong bias that systemic diseases do best when treated with systemic, not focal therapies. In the case of stable CAD, oodles of properly run and powered RCTs have shown no advantage to revascularization of focal lesions when added to conservative approaches using optimal medical therapy. My question to you all is this: what shall I do when an utterly flawed study is published in a legit journal by well-known experts that supports my bias? Should I gloss over the methodologic flaws and say, "See, I told you OMT is great"? Or should I take the opportunity to point out why the study cannot be used to say anything useful? I will choose the latter. Let's first talk about the syntax study, because this had to do with a sub-study of syntax. Authors of the original Syntax trial, this was an RCT that New England Journal of Medicine published in 2009, compared PCI to CABG in about 1,800 patients who had multivessel CAD or left main coronary artery disease. The trial was a non-inferiority trial that had a primary endpoint of death, stroke, MI, or repeat revascularizations over 1 year. Now, the primary endpoint ended up being way worse in the PCI arm, 17.8% versus 12.4%, and Syntax therefore did not show non-inferiority of PCI to CABG. The negative result was driven mostly by repeat revascularization, and rates of death, stroke, or MI taken together were similar. I then went and looked at the clinicaltrials.gov website, and I counted 36 subsequent substudies of Syntax. Now, one noteworthy one was the 10-year results of all-cause death. This study was published in The Lancet in 2019. 28% of patients had died in the PCI arm versus 24% in the CABG arm. The hazard ratio, 1.19, had confidence intervals that went from 0.99 to 1.43. The authors concluded no difference, but the bulk of the hazard ratio was well above 1 and went as high as 43% worse for PCI. The current substudy sought to assess the impact of the status of optimal medical therapy at 5 years on 10-year mortality after either PCI or CABG. In other words, did patients in either group do better if their OMT, optimal medical therapy, was optimized? The degree of optimal medical therapy was defined as how many of the big 4 classes of medications a patient was on. The big 4 were antiplatelet, statins, ACE, ARBs, and beta blockers. And you could be on 4 classes of these drugs, 3 classes, or less than or equal to 2 classes. And the authors took the available patients, about 1,400 of the 1,800, at 5 years, and they stratified them by number of drugs, and then they did a landmark analysis looking out to 10 years. And patients on ideal optimal therapy at 5 years had a significantly lower mortality at 10 years compared with those on less than or equal to 2 types of medications. It was like 13% versus 20% outcomes. The adjusted hazard ratio was 0.47, so highly significant. And patients on 3 drugs had mortality close to those on 4 drugs, about 12.9%. So it was really those on less than 2 drugs that did worse. Antiplatelet drugs and statins seem to be the most important classes of drugs, especially in those randomized to the CABG arm. Let me review the author's conclusions. Quote, in patients with 3-vessel and/or left main disease who had PCI or CABG, medication status at 5 years had a significant impact on 10-year mortality. Patients on optimal medical therapy with guideline-recommended pharmacologic therapy at 5 years had a survival benefit. Now let me read you a quote from the editorialist. Quote, these observations are extremely important in reaffirming the synergistic and beneficial effect of OMT on long-term mortality in patients undergoing revascularization with either CABG or PCI. Do you see the problem here? They're using causal constructions. Good OMT had a significant impact. Patients on good OMT had a survival benefit. These observations reaffirm the beneficial effect of OMT. I think this is a big problem. My friends, whenever authors do a post hoc study and they use patients from an RCT, they mix groups, they look at something other than the primary endpoint, it's basically a non-randomized observational study. And you can't easily make causal conclusions from those kinds of studies. Now, the first problem here, as the Syntax authors tell us, is that optimal medical therapy in this trial was not mandated by a protocol. It was left up to the doctors taking care of these patients. That means that a clinician had to decide to prescribe 1, 2, 3, or 4 drug classes. Patients on fewer meds may have been on fewer meds because they were sicker, and that is why they did worse. Now, another sign of worry. Patients receiving an antiplatelet drug and statin who underwent CABG showed a significant mortality reduction, though this benefit did not extend to PCI-treated patients. Conversely, beta blocker use was associated with a reduced mortality in those having PCI. These are strange and counterintuitive observations because there are no trials in stable coronary disease that have demonstrated a benefit from beta blocker. And what's more, why would statins and antiplatelet drugs not help those with severe coronary disease who had PCI, but beta blockers would? The likely answer is that there's a play of chance. Finally, there was a lack of precise data on the extent of optimal medical therapy use after 5 years. Did the optimal medical therapy at 5 years continue for 10 years? You think that if you were going to propose the importance of medical therapy, you'd want to know not what they started on at 5 years, but what they took from years 5 to 10. So at most, you could say that there was an association between patients who were well enough to be on 3 or 4 classes of drugs at 5 years and death rates at 10 years. But that is it. There was incomplete data, medical decisions left to the discretion of clinicians, and that's likely confounding, and there was other evidence of spurious findings. Oh yes, I still believe that optimal medical therapy is super important, along with lifestyle modifications, but I will not cite this paper due to its methodologic flaws. And I would go so far as to say that the citation and promotion of flawed studies to support a point of view may actually reduce trust in any future points one tries to make. I am not sure why these sorts of papers are published, and I will resist the urge to think cynically that it has something to do with racking up citations and improving a journal's impact factor. The final topic today is alcohol. Canadian cardiologist Christopher Labos has an excellent blog debunking the myth that alcohol is cardioprotective. As an atrial fibrillation doctor, I field a lot of questions about alcohol intake. And for AFib, 3 sets of observations seem pretty clear. In population studies, any amount of alcohol associates with an increase in AF. In an elegant, recent randomized controlled trial, alcohol cessation in patients who had PAF reduces AF burden. And in basic physiology studies, mostly from the UCSF group, acute alcohol intake promotes profibrillatory changes in the LA and pulmonary veins, and it also increases the odds of AFib episodes. Now, what I like about Dr. Labos' take is how he debunks the French paradox about red wine. The French paradox, he writes, like most medical paradoxes, is a statistical anomaly, and it most certainly isn't true. The French may have lower rates of cardiovascular disease, and the French may drink lots of red wine, but they're unlikely to be causally linked. Now, if you've ever been to France, one confounder becomes immediately obvious, and the French walk and cycle a lot more than Americans. Labos notes that other issues with red wine, and then one is that it's in fact full up with simple carbohydrates. It's grape juice. Reducing alcohol means reducing calories, which of course is a good thing from a health standpoint. Another paradox he writes about are the observational studies that find non-drinkers tend to have higher risk than moderate drinkers. I mean, why would that be? Again, you have to think about collider biases. That is, that many non-drinkers were former drinkers that have other reasons for not drinking, say liver disease or AFib or diabetes. And when you mix non-drinkers with never drinkers, you are at risk for getting this thing called the sick quitter effect. That is, people don't get sick because they abstain from alcohol, they abstain from alcohol because they got sick. Well, finally, whenever I discuss alcohol with patients, I make clear that I am not a preacher, only their advisor. I agree with the main conclusion that alcohol should not be considered a health food. It is an indulgence, one with negative effects, especially when taken in excess. But please, friends, don't get me wrong. Indulgences are fine. They make life more fun. But we shouldn't confuse indulgences for healthy behaviors. So that's it for this week in cardiology. I'll see you all in 2 weeks. For my American listeners, have a great and not too rebellious Independence Day holiday. And remember, if you like this podcast, please take the time to give us a rating, write us a few sentence review, tell your friends. These things help others find us. Until 2 weeks, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.